Good evening. I'm Sarah Loudon from Total Health Conferencing, and thank you for joining us for another podcast of inspirED. Tonight, I'm honored to have Dr. Jen Klemp, newly professor Dr. Jen Klemp from the University of Kansas Medical Center, and we are going to be talking about life after cancer. Really, the focus of tonight is going to be cancer survivorship. And we're going to hear the many dimensions of that word and how it's applied to millions of people living around the world today. So Dr. Klemp, thank you so much for being with us tonight.
Well, thank you, Sarah, and thank you to everyone out who's watching or will watch it. So it's great to be here and to talk about a subject that obviously is very passionate to many of us.
Yes, and Doc, for relaxation's sake, I'm going to call you Jen for the rest of the conversation because we like it to be kind of a living room chat for everyone listening. And I want to start with asking you to define survivorship for us, just so that we get a context of what we're going to be talking about tonight.
You bet. So when we talk about survivorship, we're really talking about anyone living with or through cancer. And so I think it's hard because many of us who've worked in oncology for a long time, the word survivor sort of is grandfathered in. And even though we did focus groups with patients and really tried to figure out what do survivors, co-survivors want to call themselves, when something's already coined, it sort of brings people together as a group. So it's truly that global definition of living with or through their disease. And the expanded definition also includes the caregivers, the co-survivors, the supporters of those individuals along their cancer journey.
So tonight I'm going to kind of talk to you as a lay person because, you know, the audience is filled with newly diagnosed, it's filled with people who are in treatment, you know, active in treatment, people who are in survivorship, those who are maybe patient advocates that work for advocacy organizations, but you know haven't themselves been affected by disease, healthcare providers, and then just the general audience, people who may have had a mom with breast cancer or a dad with prostate cancer. And so I really kind of want to cover as much as I can because I think this topic, while it's so important and essential to the conversation in cancer, doesn't always get necessarily the amount of time we need to discuss. So, you know, you've defined survivorship as people living through or with cancer. And I want to right away ask you the question that I've been asked, or I've been kind of instructed a few times when I say things like, you know, survivor, fighter, connotations of words that are taking on much more meaning now that people are kind of becoming more empowered with their own voice. Right. Do you find that survivorship means something that, you know, you've been through a battle and you have won, whereas maybe someone else has been through a battle and they've lost? I guess talk to me a little bit about terminology.
And terminology is pretty heavy. I do not ever, in any materials I use, talk about, I do not use war metaphors because I don't think it's appropriate because it does resonate so differently with people. So oftentimes, if I'm talking to a patient or their family, I actually ask them to sort of define kind of how they conceptualize survivorship. But I don't like the thought that if a patient has challenges along their journey, or if obviously they have advanced disease and the disease is something that causes them to and you know their lifespan is shortened because of cancer. I don't want them to feel like something they did is what led to that result. So I do think words are very powerful. We see that, you know, all the time, but we need to be very mindful of the fact that cancer does have its own journey for people. There are some similarities that most patients and their families experience, but I just don't like things that kind of put that guilt back on the patient. And I think that's very important for us to be mindful of. So I am not a fan of the sort of battle semantics that are out there.
Yeah, the battles and things like that, absolutely. So, I mean, I really asked that question because I want to diffuse anyone from right away rejecting that we're talking about something, because I think what we're going to try to get at tonight is the power of acknowledging that you have experienced something or are experiencing something, and that life has changed so significantly, but there's a lot of life left. And whether or not we're quantifying that, a lot of life in many years or a lot of life in experience left. What I want to do is encourage people who are living through or with cancer, that there's a whole set of resources there, people like you that are fully devoted to giving them the fullest experience. So I'd like to ask you for the typical time, you know, if I'm Sarah, I'm 43 years old, maybe I am newly diagnosed with a non-small cell lung cancer. When do I encounter a Dr. Klemp?
Sure. So I think that that's going to look and feel different depending on what type of organization you're going to. It's a community-based hospital, it's a outpatient practice, it's a academic center. And so that will look and kind of feel different. And then sometimes, which is probably one of the things that happens the most, is that I'll talk to patients, and maybe it'll be, you know, post their acute treatment, and they'll say, well, I never got to talk to anybody about, you know, quote, survivorship. But the reality is they talked to a navigator, one of our advanced practice providers, one of our nurse practitioners, and they had a lot of that survivorship experience. We just don't, quote, sort of put it in that context for them. So I think we need to do a much better job generalizing that survivorship does start at the day a person's diagnosed, and whether we're talking about sexual health or genetics or whatever we're talking about with the patient, that's all part of survivorship. And if we can kind of bring that into the conversation, then patients don't feel like, oh, well, survivorship only happens in this little box and I get a care plan and that's what survivorship is, because that's not what it is. And as you know, Sarah, I've used this sort of map since 2006 is when I built my little survivorship map that I still use today, because it's very indicative of what we mean by survivorship. And it starts from day one, and it has roundabouts, because that is part of that journey as well. Some patients will go through and have a good response, and maybe they recur. Maybe they never become disease-free. Maybe they become disease-free and stay in that sort of category. So I think the important part about sort of that visualization of survivorship is that it encompasses a very wide umbrella, and it's sort of that entire experience that the patient will go through. And it's our job to make sure as healthcare professionals and to empower the patient, like, what do they need and when do they need it, so that we are meeting the needs of patients and we're not providing too much at the wrong times, but we're really providing the right amount of care at the right time for the right needs of that patient and their family.
So you said so much that I want to dive into. I hope that I can remember everything. The first thing that I want to dive into is, I've heard you speak, and you kind of opened my mind years ago that if I'm an at-risk person, if I have a family history, if I have certain environmental risks, that really we should be thinking about testing, you know, genetic testing. Talk to me a little bit about your work, and maybe a call to action for those who should be tested for things who may not be already.
Right. So anyone who knows me out there, I've been practicing genetics for over 20 years. And, you know, the frustrating part is getting point of service testing into practice still today, even though it's such a defining piece of information for screening, for risk, for treatment options, whether it be surgery or chemotherapy with PARPs and so forth. So we have a lot of reasons why testing is important. And then for the family or the legacy. And I remember that when we first started testing a lot more in the GYN cancers, you know, we would get, well, it's not going to help any, you know, the patient's not going to matter in their treatment. And for one, I was like, but it will. So just hang tight. And then the second is, what a piece of legacy to give to your family is that understanding the risks for your sisters, your daughters, your sons, you know, and so forth. So I think the important part, and we just presented the last meeting I went to in person, Miami Breast, we were able to present our survivorship data of looking a consecutive year at over 1,800 survivors in our clinic. And even though we are a very high put-through testing practice, we have a great, you know, I think, process in place, we still needed to test another, you know, almost 200 patients out of 1,800 that needed update testing, because maybe you had testing, 8 years ago, and now we test for more genes. And we found another 12% of our patients positive from that population, which definitely impacts, what we're going to do with them. When you look at the literature, we know there's over 1 million breast and ovarian cancer survivors living right now with the risk and qualifying for hereditary cancer testing. So, where are we putting that into survivorship? So we talk about it. It's in the NCCN guidelines. It's in sort of everyone's slide deck, but how do you apply that into a longer term care model? And it's hard. It's hard to get it done earlier on, and it becomes even harder, once patients are out of that acute treatment environment.
Something else you were talking about while you were giving us your answer was the patient may have been picking up pieces of the survivorship map all along, and they may have been engaging with the healthcare providers in various areas and stages, and it was just never kind of coined to survivorship. So here you are coming towards the end, and you're thinking, now do I have to kind of consume all of this new information? Do you feel that there is an overwhelming amount of information that's kind of coming out of cancer, a patient who's living with cancer, living through cancer, and B, should we be kind of mapping, whether you're in a community or academic center, should we be mapping for the patients things that are kind of relevant short-term, medium-term, and long-term, so that they can see and follow this map over the course of their therapy and know that on the other side, they're preparing for this new life after cancer?
Yes, yes, and yes. So I think that my vision, I met with even our internal marketing team a few years ago, and I described this vision of almost having like when you go to Disney and you are here, and here's your journey you're going to take, right? So we educate as healthcare professionals when it's convenient for us, right? So we data dump, especially when people are diagnosed. And then we don't really do a lot of touch points with patients because it's not really built into our process, but the patient retained maybe 12 to 15% on a good day of what we said. And then, as they went through and they're like ruminating at 3 o'clock in the morning, and they're going to websites and blogs and doing all this stuff, where is their, Disney guide that helps them sort of navigate? And we give them every bit of information. So you could have one of 30 side effects from this therapy. And the patient's like, well, okay, but I already have 3 other health conditions, which the average patient that we see, maybe they have hypertension or diabetes or some other health condition. So is it the issue that they're having related to their existing conditions, the cancer and the cancer treatment, something that the treatment will accelerate? So you really do have to help dissect that. And I don't think we have a good structure, which is where survivorship can excel. I also think, telemedicine has really given us some more opportunity, because patients do include their care team, their friends, their family on these telehealth visits. And I think it's really helped them retain a lot more information than when they come in person. It's very emotionally charged, and we still want to see patients in person. Trust me. I'm like, it's really hard for us not to see patients, but at the same time, I do think that they're able to have that wider net to help support them and really define, so that we're not data dumping to them, and they're able to hone that information in a little bit more. So I know that was sort of a rambly answer, but the moral of the story is that we do need to, just like we do with a treatment plan, a survivorship plan should be much more personalized based on the things that are most important or most at risk for the patient, not here's your data dump of everything that could possibly happen. That's not fair.
Yeah, everything that you're saying resonates so much. And even, we just had our big cancer meeting, ASCO virtual this year, and there was like so many exciting things that came out, and really so many tumor types. I mean, I feel like I was hearing that there were tumor types that hadn't had, major advances for 20-something years, and here we had something that hit for them. But one of the things that really resonated with me was this year's focus on a shared decision-making model. Right. So, in past years, maybe it's just me, but in past years, I feel like the education has been so focused on we learned something new. We're not considering cost. We're not really considering the side effect profile. We're considering that you're going to live 3 months longer. So we're going to change practice and everybody's going to get treatment A.
Right.
But this year, I feel like it was like, we learned something new. Why does it cost this much? Somebody needs to do something about it. Let's talk to each other about what your goals are for treatment, you know, patient and provider. And then let's pick the treatment that's right for you. And I was so blown away that so many of the presentations followed that path, because it almost was like this moment for me where I was like, why wasn't it following that path in the past? And I do want to talk to you a little bit about the power of the patient voice in the room when decisions are being made about their care. How do you encourage people to speak up and speak out?
The art of shared decision making is not natural for a lot of people, and in particularly a lot of providers. So I do feel that there are certain people that are good at it, and then there's certain people where that's why you have a team, right? So you identify your strengths and weaknesses, and you do that, because a lot of us have been using shared decision making for a long time. But you also have to have several things that I think could be tips. So when I was in training, I had to do actually tape sessions with patients with their permission, and then you'd watch them with supervisors and so forth. I can't tell you how valuable that is, because you really see, wow, I wasn't picking up on the cues of the patient, or how I said that was a little awkward, and you get better with self-reflection or with having good mentors that actually tell you, you know, kind of the good, the bad, and the ugly. But then the second part of that is you can't do, once again, a one-size-fits-all for a patient, because when I was at UCSF as part of my training, we did a study on shared decision making, and this is back in the early 2000s. And it was very interesting because you realize that some patients can't handle all, like a menu of choices, right? So you give patients too many choices, and now they're really stressed out, and they're going to have potentially decisional regret. Versus another patient is like, kind of like if you read a consumer report, well, I want to know the top 10 choices. I want to be able to narrow that down. I'm going to go home and do some homework, talk to some people. Some people really are empowered by that. So I think one of the most effective tools you can use is to understand the patient sitting in front of you, how they make decisions, and how their goals are built into those decisions. So a simple question of, you know, kind of how do you make these big life decisions can really help you as a provider do a much better shared decision-making discussion. And then the second part is super basic. You and I are both talkers, but at the same time, we're also listeners. Yeah. And you have to be able to pause as a provider. First, we don't like pauses, because pauses, we like to fill the noise, and it takes too much time. But we have to be able to pause and do some reflective listening with the patient, so that we know that they are understanding anything that we're talking about. And you will find that sometimes some of the most basic things that we've said to them, they just didn't get, or they got it the wrong way. So I feel like if we could just use some really basic kind of back to improved communication skills, it would dramatically improve how we have patient-provider interactions, but it would also streamline our visits and give the patient the voice, as well as the provider the sort of behind the scenes as to what the patient's really getting and not getting, and how we best make this decision together and not be paternalistic or have decisional regret.
I mean, I just love your perspective, because, you know, we've been doing a lot of work with patient advocates since COVID-19. Our whole business kind of turned upside down on its head and did a backflip. And we had to really think about, you know, if we're not going to deliver content live, how are we going to now deliver? And one of the first things I noticed was that the disconnect between patient and provider was automatically grown because of that whole kind of, you know, energy that you feel when you're going. And not to mention that a lot of visits were deemed unessential. So there was like this moment where you're thinking, wow, so if I'm a patient and I have on my calendar, you know, a big red square around a date, because I know that's when I'm going to go see the oncologist and get some answers and make sure that everything's clear and clean. All of a sudden, this this otherwise, you know, staple in my timeline is now not essential, but to me, it's still essential. Like, I still want information. So we started connecting patient advocacy groups to medical experts to help. You know, you had mentioned on some off time that we had that you were doing this fact versus fiction, which, I mean, fact versus fiction, I feel like every day we need to start our day with fact versus fiction.
Yeah, it's called infodemics. It's like the 70% of information that's out there, especially revolving around COVID, is just not accurate. Yes.
Yes.
Scary.
We had a medical expert that called it the pandemic of misinformation.
Yeah.
I mean, this is real. You know, there are people holed up in their house and their only source of news is the television, and the television isn't giving them anything, you know, either anything valid or anything encouraging, and they're just kind of left to their own devices. Mm-hmm. But I love your perspective, because in the conversations that I've had with patients, the patient has been so, not adamant, that's not the right word, but so keen on saying, I had to find my voice. I had to find my voice in the room. I even had a patient who had lung cancer who said, I had to fire my doctor, because, you know, you don't think of the term like fire your doctor. You never really think of it as hiring a doctor. But he was like, the doctor wasn't right for me. And so it wasn't anything wrong with the doctor. It's just that we didn't match. So I had to fire my doctor and go to this new doctor. But the way you're saying it with shared decision making, you're putting the emphasis, I know it's shared, but you're putting the emphasis on the provider. And I love that, because I think for patients, so many times it's like you sit there and go, I really want to ask a question, but I can't. I really want to. And here you're saying, provider, it's up to you to recognize that cue and take the pause and listen. Ask them, do you have any other questions? Are you sure? Is there something you want to say? Right. So I love that. I love that about the way you're saying this.
But the one thing I'll tell you that you just brought up that I think is so poignant to this conversation has to do with patient expectations. Like you said, the patient, quote, fired their doctor. I do think a lot of times we have the wrong expectations about what healthcare can and can't do. And I know, you know, you've heard me say this before, you know, medicine isn't black and white. We have so much gray. And we also have a real unrealistic expectation sometimes. Like if you could say, do you want to go to the doctor who's going to treat you with the most, you know, evidence-based, cutting edge, you name it, but you're not going to gel with their personality. Frankly, you might not even like them. Are you going to choose that person over somebody who you click with and connect with, but, you know, maybe doesn't have access to the top clinical trials? You know, people are going to make different choices, but I do think they need to have realistic expectations of what healthcare can and can't do. And I think right now we don't spend enough time preparing the patient for the visit, right? We prepare them by getting all their information and doing that, but we're not preparing them for how to be a patient. And I think that is something I wish navigation could do, and we could really empower that as part of our process, because it's frustrating on both sides. Then you have patients that are frustrated and you have providers frustrated and care teams frustrated because we're not on the same page.
Yeah, and it really is about laying the expectations. In every other interaction with some type of professional, whether it's someone laying pavers in your front yard, to a lawyer that you're hiring to write a will, an accountant that's doing your taxes, sure. In every other interaction, it's almost like the two parties come to each other from a level playing field and almost set those expectations. But I feel like when you're a patient that's diagnosed with cancer, or even a caregiver, taking care of a patient that's either newly diagnosed, and this is all a new world for you too, you're in such a vulnerable place.
You are.
That, you know, you're there kind of listening and hoping and learning and trusting. You're trusting a stranger with making decisions, you know, that are right for you for the rest of your life, and hoping that they are, like how you said, you know, someone who's up on the latest knowledge, who maybe has access or is aware of the latest clinical trials, et cetera. So, I mean, it definitely is an area that I think the communication and information needs to increase. And like you said, before day one, visit one, the expectations on both sides really need to be established. So
Right.
that's
Well,
an awesome thing that you've had us start thinking about.
Well, and you brought up a good point, and I've often thought about this. You know, you brought up, like, if you are contracting with a lawyer or an accountant or somebody to do the papers or whatever, you know, things are clearly laid out in the contract. And do we need to have sort of this contract? And I just published with my group from SWOG on digital engagement, and we're thinking through kind of social responsibility of stakeholders in social media and clinical trials and all this type of thing. And do we need some sort of written contract that, you know, if I'm on a trial, maybe I shouldn't be out tweeting certain things because maybe that's going to confound the clinical trial, right? So at what point do we have kind of roles and responsibilities laid out? No, we don't want to be as formal as a contract, but there does need to be a better understanding. And I think the advocates can really help with that.
Yeah.
I think engaging, you know, both the providers, the advocates, the health systems, you know, all those key stakeholders have to be around a table to have that conversation. And then it's still never going to be perfect. So, you know, how do we have some flexibility, and how do we kind of give each other a little bit of a break, but work together to make it better? And those are things where I do wish we had a little bit more understanding of each other, especially right now. And instead of, I feel like everything's so high expectation, and then we always let people down.
Yeah, no, absolutely, well said. So, you know, you mentioned advocacy, and that's where I wanted to go next with our conversation. You know, I said that we've been doing a lot more work with patient advocacy groups, really in every tumor type. Even in hematology, we did a leukemia town hall, and I was, you know, the format of those meetings where we pulled together 3 advocacy organizations of different sizes, you know, different reach, and we kind of match them to medical experts, and then, you know, have like patient testimonials. And Jen, I was so moved by the level of passion and organization and impact that advocacy organizations have, from small to large. I mean, we had a woman who, you know, picks up the phone. She has a list of patients. She picks up the phone every day and she calls them all just to check in. Do you have everything?
That's amazing.
I mean, I sat there thinking to myself, like, that's how she spends her day, giving of herself to make sure, you know, check in with these other people. At a time where checking in is so important.
It's so important. And
it's so important. So how do you see the survivorship model and the advocacy model working better? How do you, if you had that perfect world, that perfect call to action, what does that look like?
So the example you gave, we can totally build on that, because when you think about things that people used to try to do even 15 years ago, you know, when my mom was diagnosed in 1994, the best, you know, example was somebody trying to match her up with someone who was younger and had advanced disease, and trying to really get those two, you know, a similar person to be able to talk and have that experience. But now we worry so much about liability. Like, we don't want to have peer-to-peer programs, because what's the liability for the organization or the hospital? So everything has gotten so much more unnecessarily complicated because of, you know, bringing you, everything just gets more complicated. So I think that somehow we need to kind of go back to the basics. You know, people do want to talk to people like themselves. They want realistic hope. And that's another piece where, you know, I think we're not always good about giving realistic hope, because everyone always wants that piece of hope to work towards. But sometimes we have to have honest and candid conversations. And that goes to the quality and quantity of life, not just extending the life, but how do we extend it with the best quality of life? So advocates can really help us, I think, frame a lot of that, but we do need to be able to somehow get back to the basics and not have everything be so complicated. And I don't know how to answer that, but hopefully, you know, as you bring these folks together, we can start working towards those goals.
Yeah, I think when I kind of worked through, and I mean, Jen, this was lung cancer, breast cancer, kidney cancer, prostate cancer, leukemia. I mean, every type of cancer, you heard this kind of anthem call, which was connection is key. You know, we all want to feel connected, and you're not alone.
Right.
You're not alone. And every time when I think about survivorship, when I think about you, and when all the times that I've heard you speak, that's what resonates to me, that it's like, oh, look at everything that's available when I'm going through something that I feel so isolated and lonely.
Right.
There are people there that are giving their lives, their careers to developing not a safety net, but like an environment where I'm seen and I'm heard and I'm known. And I love that, not only is it on the academic side, but there are all of these patient advocates, these volunteers, patients themselves, they're craving a way to give back. And I think that that's definitely steps towards what you're talking about, this, shared conversation where all of us need to learn to listen even more.
We do. And technology can help with that. So I think, having these types of forums, whether you're using Facebook, whether you're using, Hangouts, that's really bringing a lot of people together who do feel isolated sometimes, or maybe they don't want to necessarily say much, but they want to be part of a conversation. So I think that the rapid fire of, I've done telemedicine for years and my whole practice is just telemedicine. So it's kind of business as usual for me. But when you think about how many people had to, within weeks, really get comfortable with telemedicine, that includes patients and our care teams and hospitals. I think this can be a real good way for a lot of those isolated individuals to really start connecting with those support systems that they need.
Mm-hmm. Definitely. You talked about we've had to all make these changes, patients, care teams, really everyone. I don't know that there's anyone on the planet that's been unaffected by COVID-19. And while I don't want to spend a great deal of time on this, I think it would, kind of be ignoring an elephant in a room if we didn't. So, here we're all kind of living our life and everything is the status quo and we're building all these systems and we have all of these programs. And then COVID-19 comes like a thief in the night and steals it all away from us. And then we're all living this new and uncertain normal. Can you just describe, how do you continue creating robust environments for survivorship programs and conversations despite COVID-19, whether or not you're in community practice or you're in academic medicine?
Right. I think that COVID, as I said, kind of rapid fired us into technology. So we are going to have to figure out how to make sure that patients are comfortable with technology, as part of their onboarding. That can't be sort of a secondary, because we've had so many patients where, thank goodness they have other people that were being quarantined with them, because maybe it's their grandchild or their partner, whomever, has been able to help with the technology. So I do think we have to utilize that a lot better and figure out how to, in particular, make sure that patients, regardless of what quality of tools they may have, they have access to connection. And being from a rural state, we constantly are and it's ironic when we'll write a grant, they're like, well, why don't you guys just do a web conference for this? And we're like, do you know how much of our state doesn't even have high-speed internet still? So, there's still this big disconnect. So I think we have to get more comfortable with technology. And then I think that as we think about survivorship, we're going to have to be much better at identifying what that individual's greatest risks are, so that we're I think, being a lot more purposeful and targeted with our interactions. And maybe it's more short interactions versus a lengthy one, or maybe it's making sure that we're covering the top 3 biggest priorities, which, think about some of our long-term survivors, whether it's breast or prostate, their chance of dying of heart disease is equal to or greater than their chance of dying of cancer in a lot of cases. So, we need to be focusing on some of these really pressing issues for our patients and prioritizing them. I call that risk stratification because I come from a genetics world, but I think we absolutely have to do that. And that's going to make us better at doing it, because we're not going to have the luxury of patients being able to see 5 specialists. And like you said, you can't just go and wait in a waiting room with with 30 other people and go to, 3 visits a week. This isn't practical anymore. So we're going to have to get leaner with that. And that means we need to get better at stratifying the patient's risk and really helping them be part of that too. But us making sure that we're not just checking some boxes, but we're being very purposeful with that assessment, education, and then, whether it's referral or intervention for that particular patient.
And, as you were talking, I was thinking, you always focus on this isn't one size fits all, that we really need to be looking at survivorship care plans
right.
Individually. So, I guess highlight for me, maybe just throw out a couple of scenarios of what looks different for a young woman with breast cancer. Throw out a couple of scenarios on how even one group could be individualized care plans.
Right. So I think when you're talking about certain populations, there's certain things you can already sort of dichotomize or put into buckets, right? Younger patients are going to have more potential for late effects because they have a lot longer potentially to live. Older patients have a lot more comorbid conditions. So you look at younger and older as already sort of your most vulnerable. Then you look at a lot of people in the middle. And so when we think about sort of, kind of a checklist, like what's most important. So we try to give patients a patient-reported outcome, and they're supposed to check things. We're supposed to check off, an enormous amount of systems for our patients. This is not always practical because that means it's going to be that would be a long visit if you did all that. So I think that the important part is to do some baseline assessment, knowing what your patient's even walking in the door with. And this may sound crazy, but you would be surprised how little you often know about some of the other comorbid conditions in a patient that's starting treatment. So doing a more systematic approach to what is their cardiovascular risk? How is their diabetes being managed and who's doing that? Having some of those basic understandings. And then when you think about younger patients, they often have issues with, they have kids at home. Maybe they also have kids and parents they're taking care of. They're working full time. Financial toxicity absolutely affects everyone. It doesn't matter sort of across the board, but that's going to look and feel different if you're a primary breadwinner. Maybe you're a single parent, maybe you have colon cancer, breast cancer. You're trying to do a treatment. You have 2 kids at home. You're working full time. You have to keep your insurance in order to get your health care. So I think that these are the things that, frankly, that doesn't take a lot to glean, but we do need to have a systematic approach, whether it's from navigation or whether it's from how we intake and manage our patients. We need to think about things that are most important for our patients. We focus a lot on sort of those quality of life issues, whether it's psychosocial support, whether it's sexual health, which has been a very undermanaged issue for so many of our patients, but so important for them. And if we don't ask certain questions, they're not just going to share things with us because number one, they don't want to bother their oncologist with things that aren't directly related maybe to their treatment. So we have to get better at asking some of those important questions, making the patient feel like they can actually share that. And maybe it's not with a physician, maybe it's with the nurse practitioner or the nurse or someone else. And so we have to be better at leveraging our teams to do team medicine and not just think that only that one person can do everything, because that's not possible, not realistic. So I think I just rambled on a lot of different solutions, but we do need to kind of change the way we care for patients, and team medicine works a whole lot better than just trying to depend on one person to do everything.
Yeah. So if I'm that same patient and I'm right now going through active treatment and I'm at a small community practice, it's, 3 doctors and I'm in a rural area and no one's really, I'm, listening into this podcast and no one's really had those overarching conversations with me or even anything that sounds remotely like what you're talking about. That's not always, the fault of the practice. Sometimes it's just resource-wise, they don't have the ability to offer these things. How then, as a patient, can I access some of these, resources, tools, et cetera, to help me build my own survivorship plan?
And that's a great point. And we have I mean, every state has those practices, or we have practices where maybe the oncologist only goes out once a week, right? So you're left with our primary care partners who have been, you know, siloed from a lot of the care. So there's several answers. One is, you know, we're lucky to get a really big grant from the NCI to look at how do we empower primary care to be part of that team, because I do think that we need to have not only role delineation so that primary care GYNs feel comfortable being part of that. That's really who the long-term relationships are for our patients, who they have had a longer relationship and will continue. The second part of that, and unfortunately it is dependent on a lot of technology, is that support organizations, cancer care organizations, they have virtual support groups. They have resources. There are so many tools out there, and how do we get those tools to the patient? And so one thing that is helpful, a lot of the organizations that are out there, whether it's like a cancer support community or whether it's the Young Survivor Coalition, depending on, you know, kind of the age group you're dealing with, people can actually just call them and they actually help match up resources, whether they be virtual, whether they be videos that they could send the patient, whether they're print material. And so I think the hardest part is a lot of times patients feel paralyzed, but we as a cancer care delivery system need to at least have some basic resources where patients can reach out, or maybe we develop a mechanism that, no, we don't have the resources for that, but who does? Is it longevity? If it's a lung cancer patient, you know, there's so many great resources out there, and how do we really help the patient get to those? And a lot of them are underutilized by certain patient populations, and part of that is our fault. If we can't do it all, then we need to at least be able to link patients up to a lot of those resources, because we can't do it all.
Mm-hmm. And, you know, for the patient that is feeling overwhelmed with managing, you know, the effects of treatment and, like you said, of life, you know, whatever their life situation is, I feel like none of us too have escaped, you know, the 7 stages of grieving going through COVID-19. So, you know, even the strongest of us have found ourselves wondering, when will this be over? And, you know, what will the new normal look like? How can I take control of my emotions? What do you say to those patients to balance, you know, everything that's going on in the environment? Because I know you've been active in, you know, developing programs to talk to people during this time. What do you say to people, since we know that outcomes are greatly affected by, you know, emotions and self-care?
Right. Well, and it kind of goes both ways, right? So we have some patients who don't want to miss their appointment, so they're maybe not as truthful on a screen, because we screen patients when they come in, we take their temperature, and so they may not disclose that they were exposed to somebody who's been somewhere, because they want to see their doctor and get their treatment. But then there's other patients who are terrified to come in, and they've said, well, if I can't even bring a guest with me, it must be really scary there, you know? So when we're just literally trying to make sure that we can accommodate as many patients as possible, as safely as possible. So there's a lot of sort of that trust issue that we have to rapidly diffuse. And in this situation, I think that we need to do all sorts of, on local news and all sorts of things, telling people that it's okay that if you need to go to the hospital. I mean, our emergency departments are crazy right now because people haven't gone for things that they should have been going for. And so there's a lot of really sick people, not with COVID, in the hospital who probably needed to go a while ago, but they've been sort of paralyzed. Mm-hmm. So our cancer patients are equally in that. And then we have a whole group of patients who, you know, we've put off, like you used the word non-essential. And so they're like, okay, well, when can I get my colonoscopy? Do I need to do that? And so we have a lot of catch up to do now. And so once these floodgates start to continue to open, we need to get people in who've been symptomatic and haven't been screened or haven't had a biopsy. We had a dip. Every single cancer center across the country has had a several month dip in new patients. They're still there. They just haven't been able to get in the doors. So there is this a lot of anxiety happening right now, and I get it. And so how are we going to help control that conversation? And I think the first is we have to sort of own that these are issues and have the conversation. And then we need to triage patients to get those in who are symptomatic, who have a lump, who've had rectal bleeding, you know, those types of patients who are having active problems versus the person who's just a very good annual screener but has never had anything abnormal. So we really do need to be able to very efficiently communicate that need to the patients without adding more stress to their life. And I don't know a perfect answer to that, but I know it has to happen because we have a lot of catch up to do.
And Jen, do you think that it should be a tiered approach? Meaning, you know, if I'm a 43-year-old, otherwise healthy woman, no lump, should I be thinking my time's coming up for my mammogram, I should call to see if I should get it? Or do you think we're still in the time where, you know, there's a symptom and I'm saying I'm kind of scared to go in?
Well, it's hard because then there's the business side of medicine, right? Would they need to fill up their imaging center? I mean, because they've been at a deficit as well. So there's this perfect storm of the business of medicine and the science of medicine happening simultaneously. So I want our imaging centers to be full yesterday because they need to be, and I want the right patients getting in. So we can't force a patient to come in, but I do think if we have patients with acute needs, we should definitely be getting them in as a tier 1 versus the otherwise healthy person who's had clear screens. Maybe they wait an extra month or 2, but we're getting in those acute patients or highest risk patients.
Mm-hmm. So if you
That's
have
not a great answer, and I'm sure people will not like that, but
no, but I think it's listen, I think that that's what this is, like real talk. I think that this is what people want to hear because they are so tired of hearing, you know, the fear mongering going on with don't leave your house opposed to everything's open, you know, like nothing ever happened. I think we've got to have this balanced conversation about what's real. But I think your takeaway is don't delay any longer. If there's been something that's been going on with you and you've been afraid,
that's correct,
you know, to go to an emergency room or to schedule a visit with your primary doctor, you know, don't delay. The time now is not to delay.
And if you're symptomatic, the time was yesterday. So
yeah, the time was yesterday. Yeah. And it's more, you know, you want to make sure that you're not avoiding something that has much lower of a chance of killing you than something that's very serious that we need to address early on so that we can catch it and control it in a way that, you know, needs time and attention.
That helps with survival. That's absolutely.
Yes, that helps with survival. Absolutely. So, well, I think that that's really helpful too, because, you know, again, I'm, you know, I went to the doctor today. I'm one of those patients that I was sitting there going, could I wait? You know, should I go? There's been something going on with me.
Mm-hmm.
You know, should I, even in my mind, should I bother my doctor with this when she's has so much else on her plate? And I actually said that to her when I saw her today. I was like, I almost didn't come. I was going to reschedule because I was thinking like, you know, you're busy with other people. And she said to me, no, you know, I'm busy with you. Like, you're my patient. Right. So I want you to come in and I want you to express, and I want us to take a look at what's going on with you. And I think it's good to hear someone like you give us permission that we don't have to be scared to take care of ourselves.
And people can't be scared. I mean, the one of my best friends was over yesterday, and she works as she's a radiologist. We were chatting about this very issue, and we were like, and now people are so sick because they have delayed, and you know, some of that could have been prevented if we could control the fear conversation, and that is what has to happen. Everything from every media in you know, outreach of a hospital or a clinic to, you know, be nice if all media kind of took some personal responsibility with that. But we cannot keep, you know, people who are postponing going because they're so afraid when the thing that they're postponing is way worse potentially for them. Now, not necessarily, but we still have to have something sort of rational around this. And I think that people have just been cooped up and they're scared, and we need to make sure that they realize there's safe processes in place so that hopefully things don't happen. And they're pretty strict, you know, protocols that we all have. So it's a pretty safe environment out there for the most part.
Yeah, yeah. Okay, so I also know that, you know, self-care, physical exercise, diet, the environment, you know, your stress levels, all of those things are part and parcel of the survivorship care plans post-cancer, whether you're going through treatment or your past treatment. I have to say, Jen, I mean, COVID hit and I feel like I haven't worn my sneakers in 3 months. You know, you're in the house, or you're the opposite where you're outside. I mean, my cousin shared a picture of her husband, and, you know, the shirt tan was like, I wrote sunscreen and like huge, you know, letters on her social media, because you're not even considering like, oh, I have to take the regular precautions as I would have before all of this. So, you know, the audience again is filled with this mixed group. Talk to us about the evidence for all of those elements being essential to taking care of yourself in survivorship.
Absolutely. And, you know, it's interesting because there's that kind of dialogue going around about the COVID-19 is sort of like the freshman 15, right?
Yeah.
So a lot of people that have been wearing sweatpants, you need to get out of the sweatpants because frankly, that's not helpful. So I make sure I don't wear sweatpants every day. So it gives me some motivation. But I think the key that you bring up is that we give patients very little control over things in their care. Right? So you show up at an appointment, you come to your appointment, that's controlled by the patient. But if we could make lifestyle part of that recommendation, right? So part of your responsibility is to make sure that you stay moving as best as possible, depending on your limitations. And we're going to help assess, you know, and give you some guidance. But we have a lot of people who were way more active before their diagnosis. And then due to the diagnosis, they become significantly more sedentary. They're not moving, and there's no reason that they shouldn't keep some active lifestyle. And then, as we all know, once you become more sedentary, it's harder to get going again. So I do think that if we were doing the best thing for the patient, we would also prescribe, you know, lifestyle as part of their responsibility, making sure that they're eating healthy. Maybe, you know, we're constantly looking at different ways of diet and exercise interventions to look at things that like inflammatory markers or things that are associated with increased risks of or associated with not just cancer, but cardiovascular disease and so forth. So whether it is, you know, intermittent fasting, whether it is, you know, people trying to cut back on carbohydrates, there's so many diets out there. And the funny part is that when people do comparisons and like throw them all in the salad bowl, if you are consistent with any of those, you're pretty much at the same place as somebody else on any other diet at a year or 2 years from now. So the key is just sticking to something. And for the most part, we recommend patients go to Weight Watchers because it's a balance. They don't have to totally, you know, get rid of things in their life. And it's something that works for any type of person. So the key is being responsible in the sense that that is your kind of call to action for a patient, and it's something you can be in control of. And we do know that especially as we get older, as our hormones are more influenced by fat instead of sort of our younger ways that hormones were produced, the importance of lifestyle becomes even more of a hopefully risk reducer. So it's really hard because then people once again do a little self-blame or, you know, I never want people to feel like, oh, I gained 20 pounds post-menopause and I caused my breast cancer. That's absolutely not the case. It's one of many factors, but it is a factor we can help control. So how do we help patients with those factors? So I think that is a prescription we should be giving to every single patient. Plus, they just feel better. So I think it's you know, a win-win for both quality of life and for risk reduction.
And that goes for stress too, right, Jen? Because like,
Absolutely.
you know, you get diagnosed, you're in treatment, you're going through all these side effects, you feel, you know, the guilt of being a patient. My husband had to leave his job, or my daughter has to take care of me, or whatever it might be for the season that you're in. And it's like, you know, we may eat more, or we may fall into depression and move less. And so the mental part of that is just as almost prescriptive. But I noted back to when you were talking about, for doctors, the communication is not always easy. You know, doctors have to learn how to communicate, how to pause, how to listen, all of those things. And I also think for oncologists, I mean, I spent years in an oncology office as a researcher. And I remember thinking, you know, here comes an obese patient and the doctor is treating her cancer, but he's not treating her disease, her, you know, comorbid disease.
Right.
And it was like, it's because his goal, this particular doctor, I'm saying his, why? His goal was to cure the cancer. So to him, it was like, let primary talk to her about, you know, her weight control, or let cardiology deal with her high blood pressure, or whatever it might be. But the reality is that doctors, for the most part, and even nurses, are very uncomfortable crossing that line of, you know, what could possibly offend you, when really you're speaking still in medical terms, that, you know, being sedentary, not having the right diet, being overweight, all are contributing factors as you're going through this journey. So how would you, or how do you communicate with your peers that this is a permissible conversation? And maybe you even ask your patient, can I talk to you about your weight?
Right. And I think the hard part is, like, if I've had so many patients who've said, the very first line is, I'm an obese, you know, patient, because that's a medical term. So those terms are so offensive to patients oftentimes. And so the reality is that, you know, there are things that we need to do to stay mentally and physically healthy. A lot of them overlap, and a lot of them overlap with cancer, cardiology, diabetes. I mean, they're all a very similar recipe. So one thing that we've tried to do is have similar language that our cardiologists use, that our endocrinologists use. Like, we should all be using the same language. So you were correct that we need to be more comfortable with that dialogue, because it's what they need to hear from every single provider that they see, not just the primary, who has 15 other things to cover with them in a 15-minute visit. There is a teachable moment, and there's quite a bit of literature, especially when patients are diagnosed with cancer, that you have this window. It's like a 3 to 6 month window that is the teachable moment. And whether that's smoking cessation, whether it's getting patients to exercise or to eat better, that is your window. And so what do? We say, oh, well, the patient has too many things going on right now, they can't handle one more thing. Well, do we ask them that, or we just don't want to deal with it? So that's our sort of our mantra. So I do think if we can use that as, this is your homework, and I give homework to most of my patients. And so if that's the homework that you're going to focus on, is how do you do one small thing, one small step? You know, those are the ways that we can start engaging patients, and they can feel that they can hit that goal, that little tiny goal. You don't give them, I need you to go out and exercise 3 times this week for an hour a session, because no, they're not going to do it. It's not going to happen. So how do you help them kind of do SMART goals? How do you encourage that is part of the responsibility from day one? It will make them feel better. It will make them, you know, engage better. And then it needs to be from every discipline that they see, because we should all be giving the same message anyway. And then there's great tools out there. If they don't have a lot of energy or can't, you know, walk down the block, there's chair exercises, and there's so many things. So they don't even have to go anywhere. There's great resources available, and we need to encourage our patients to use those.
Yes, yes. Well, I always, we've got just a few minutes left. I always find you to be so informed, so inspirational in terms of the way you look at bigger picture things, but you bring it back down to the individual patient. I think that that's a little bit of your power, that you can look at things on a big scale, but then think of, you know, Susan next Tuesday. Because I think that's what, you know, you're doing it for. You're thinking of these big plans and development, and, you know, grants and access and resources, all because you've seen what the lack of does to people that come in to your clinic. So I'm always in awe at the way you think and you act. In these last couple of minutes, Jen, I want to just give you the floor to say, you know, you have an audience of people that are listening. What's your message? What's your takeaway about life after cancer and the importance of survivorship?
And thank you for those comments, Sarah. I feel the same way about you as well. I think we align because we are big kind of picture thinkers. But I think that there's not someone out there that's not touched by cancer, right? So whether it's, you know, we work in this because of a parent or a loved one or whatever the calling is that makes us work in the field of cancer. Whether it's when I teach high school kids and I say, okay, how many of you know someone or you're a family member with cancer, and every single kid raises their hand. You know, so we need to have these conversations early and often. So that means we do need to sort of normalize that as young as possible. We work with a lot of high-risk patients that are, you know, midlife, and they're like, how do I reduce my risk? Well, I wish I would have talked to you when you were 10, because that's when we want to start those behaviors and get you moving and all that. So I think the biggest recommendation I would have, and I use this in my own life as well, every day is a new day, right? You push a reset button, you can leave the other behind, and if you're trying to implement new lifestyle behaviors and you didn't do, you know, your on program yesterday, today's a new day. So sometimes people write that off and like, oh, I screwed up this week, so the whole week is gone. No, the whole week's not gone. And so we put so many rules and regulations on ourselves. And I think we have to let that piece go a little bit. We have to have realistic expectations. We have to put things into context and give people a break, but still hold people accountable. So there needs to be a balance in how we do that. And I do think we need to, as healthcare professionals, really think about our role and how we use our teams and how we prepare our patients better. And as patients, they need to ask, okay, what is my homework? What do you want me to do? How am I an active member in this? And they can't be passive. So we each have personal responsibility. We each need to think about how we're in this journey together, and we need to figure out how to communicate and live symbiotically. And then we need to figure out how, as patients live with their cancer, some for the rest of their lifespan, or as patients live disease-free from their cancer, you know, how do you still maximize the experience of cancer? You know, it is something that changes every single person in different ways. And, you know, how do we help those that need a little more help? How do we let people know that don't need as much help, that we're there if they need us, and really allow patients to fulfill their goals, whether it's getting to their granddaughter's wedding in a month, so we kind of flex our treatment, or whether it's they want to run a half marathon, you know, 6 months from now to celebrate that they're, you know, 5 years free of cancer. You know, these are all things where goal setting can be so important, and helping patients hit those realistic goals is something that we could work on with them. So push reset, give yourself a break, move forward, and don't stay stagnant. We've got to keep moving. So.
Mm-hmm. I think that's sage advice for everybody,
Yeah.
not just for patients living with or through cancer. Dr. Klemp, I've loved having you on. I always love spending time with you. I'm so grateful that you're on this journey with me, and I look forward to the time that we're able to be together again.
In person. I know. I think we all are connectors, right?
Yes.
What humans do is connect, and so we're all craving that. And so I can't wait to see everyone again, and anyone who's out there. You know, obviously through Total Health Conferencing or my email, you please feel free to reach out, and we hope to see you all again soon.
Soon. Thank you. Good night, everyone.
Bye.